Um, I'd now like to talk about evaluation and management, coding and billing. Evaluation management is the process of evaluating and managing patients, and it's the bread and butter of what all providers do in almost any location, any time, when they see a patient and they create a plan for that patient. The objectives of this lecture are to understand the basics for coding evaluation management services, understand the documentation requirements. There's documentation requirements that have to meet the levels that are chosen, and that may be different based upon the site of service, and also understand the best practices for that documentation. In the office setting, using time or medical decision-making for code selection, which then translates similarly over to other locations. And when choosing a level, one chooses either time or medical decision-making. And then there's also modifiers. There's 3 evaluation management modifiers that can help dictate the payment for a service which may not otherwise be paid if the modifier was not added, and also the rules around it to know the appropriate use of these modifiers. So evaluation management codes are owned by the American Medical Association. They're all 5-digit codes. And again, this describes the process and the work of evaluating a patient and managing that patient. There's codes that exist for almost any location and any situation when it's medically necessary to evaluate and manage a patient. The basics and what we need to know for urologists is that typically we're going to use 2 different sets of evaluation management codes. Our outpatient code, which would be any outpatient site of service, office or ambulatory surgical center, are outpatient sites of service. Hospital sites of service, we talk about both inpatient sites of service and observation unit sites of service. So there's different codes for each one of those. So outpatient, a patient is either going to be new, established, or there's going to be a consultation. We can also perform telephone visits, and there's actually a CMS only code called a brief check-in code. Hospital sites of service, inpatient consult, which typically is only being billed for private insurers because Medicare does not accept consultations. Initial hospital care, that's the initial time and the initial visit of seeing that patient. Initial hospital care will be billed by the admitting physician or by a consulting physician on a Medicare patient. It's the initial time that patient is being seen in the hospital that day. Subsequent hospital visits every subsequent day that the patient's being seen, whether by the admitting service or a consultation service. And discharge date, that is the admitting provider can bill a discharge service. The consultant would not bill a discharge service if they're not being discharged from their own service themselves. And there's also the observation unit. If the patient is in the observation status, there's initial observation day care, subsequent observation day care. If same day admission and discharge from the hospital actually has slightly different codes, there's a little more work involved with admitting and discharging patient on the same day rather than just admitting or just discharging, and discharging from observation. So these all have unique codes. So once again, how do we bill for these codes? E&M code needs to be associated with a ICD-10 code to create a bill. The question is whether a modifier is needed or not in certain situations. We'll get to that. Goes through a whole bunch of computers, and then the insurer pays us for that service. Obviously, we can always get audited for those services afterwards. We want to do it right beginning. So let's talk about outpatient codes. So right now in 2021, outpatient codes have been updated for new patients and established patients. Consultation codes still use the old 1997 guidelines, which have different amount of time and different documentation requirements. But the basics of what we do, we receive new patients and established patients. The codes, for all intents and purposes, we're going to build level 2, a level 3, a level 4, or level 5. The only difference in the code is whether the patient is new or established. It just pays a little bit differently, except that the work that's being done to achieve a 2, a 3, or 4, or 5 remains the same and remains constant. There's an add-on code, which is for extra amount of time if using time for billing. So if doing medical decision-making, using that for level 2, 3, 4, or 5 decision, patients either can be straightforward, low, moderate, or high amount of medical decision making. We'll go through how you calculate whether a patient is straightforward, low, moderate, or high in a few slides from now. If billing based upon time, you can see the time ranges. So if you spend 15 minutes on a new patient, you'll bill 99202. If you spend 30 minutes on an established patient, you'll bill 99214. So it's within those ranges. So you either use medical decision making or time when billing a patient. Again, we talked about the old 1995, 1997 criteria and the new 2021 criteria. The 2021 criteria, again, is only for new and established patients, but not for consults. In the 1995, 1997 criteria, we had our history had a certain number of descriptors: onset, location, duration, exacerbating signs or symptoms. In 2021, just have to do a medically appropriate history. The examination, you have to meet certain criteria for the old examination. In 2021, the medically appropriate examination needs to be performed and documented. To choose the final level, you either use time or history, examination, medical decision-making. In 2021, you either time or medical decision-making. Medical decision-making has 3 sections. We have to get 2 of the 3 sections to bill a certain level. In 1995, 1997, the time would be face-to-face time, where 2021 is the total time on that day. And the day of that service, the pre-visit work, the intra-visit work, and the post-visit work is added together. In 1995, 1997, if using medical decision-making, hit 2 of the 3 highest between diagnosis, data, and risk. 2021, it's really about the same. You have to hit 2 of the 3 highest. And there are no add-on codes for extra time in 95, 97, but there are these add-on codes for both non-Medicare insurance and Medicare insurance. There's also a complexity code for Medicare, but that was delayed until 2024. We'll talk about that if that ever is actually implemented in 2024. So what do you need to document? Again, history and examination must be medically appropriate, but don't use this as an excuse for poor documentation. History needs to describe the medical necessity for the visit, needs to communicate between providers, medical legal reasons, and protection from audits are all important reasons to write down a very adequate and appropriate history. Once you do a history examination, the level choice is based upon time or medical decision-making. Again, using time for code selection, this includes both the face-to-face and non-face-to-face time personally spent by the physician or other qualified healthcare professional on the day of the encounter. Day before, day after don't count. It has to be on that day. If you are seeing a patient with another qualified healthcare provider, such as a physician assistant or nurse practitioner, you can sum the unique times, non-overlapping times together to get the final level. Now let's talk about medical decision-making. Again, we talked about reaching 2 of these 3 levels. So between problems addressed, data, and risk, if we had a 4 and a 4, the patient's going to be a 4. If we had a 4, a 5, and a 4, the patient's going to be a 4. The point is you have to hit 2 of the 3 highest needs to hit a certain level to choose that level. So go through each one of these sections to understand how to get each one of these levels. So let's talk about problems addressed. The problems addressed are the problems that are being seen, the reason that patient is being seen on that day, and the problems are being addressed by the provider. So for example, level 2, if the patient is being seen for a self-limited or minor problem, a self-limited or minor problem may be a bug bite, maybe a scratch, maybe something that really doesn't need treatment. It's not going to cause any harm. It will potentially resolve on its own or very minor treatment. A level 3 would be if 2 or more of those self-limited or minor problems are being addressed and medically necessary to be addressed on that day. A stable chronic illness, something that's going to last for more than a year or the lifetime of the patient, is stable chronic illness. An acute uncomplicated illness or injury, something that may need minor treatment but should resolve completely. Let's use acute cystitis as an example. Some antibiotics that the patient probably should resolve completely. A level 4 problem would be a chronic illness that's worsening, or their side effects of treatment, or just not at their treatment goals. Level 4 may be 2 or more stable chronic illnesses are being addressed on that day. An undiagnosed new problem with an uncertain prognosis. Let's think about a gross hematuria evaluation. We don't know why the patient has gross hematuria, but it could be something that's bad that's lurking underneath as the cause of that patient's gross hematuria. So we have an uncertain prognosis on what we might find. during that evaluation. An acute illness with systemic symptoms such as pyelonephritis or prostatitis, patients got fevers, patients got chills, systemic symptom. An acute complicated injury, loss of consciousness during a trauma, for example. A level 5 problem is a chronic illness with a severe exacerbation, severe progression, or severe side effects of treatment. Think about a patient who has to be admitted to the hospital because they have new leg weakness due to metastatic cancer to their spine. Acute or chronic illness that poses a threat to life or bodily function. Think about a heart attack, acute myocardial infarction, a stone with sepsis. The patient's in the ICU is an acute or chronic illness that poses a threat to life or bodily function. So once again, some people try to interpret level 5 diagnoses to how they want it diagnosed, to how they want to interpret it, but really it's written out that it's difficult to get to a level 5 diagnosis, and the patient has to be pretty sick. And again, acute or chronic illness that poses a threat to life or bodily function, sepsis, acute myocardial infarction, pulmonary embolus, severe respiratory distress, peritonitis, abrupt change in neurologic status. Those are all level 5 diagnoses examples. And again, someone who may need to be hospitalized because of severe exacerbation, that would be a chronic illness with a severe exacerbation. Now let's get on to data. The data, I think, is one of the more challenging ones to try and remember how to get to a level 2, 3, 4, or 5 data. Basically, if you're doing minimal to no data, it's going to be a level 2. To reach a level 3 for data, you have to hit one of the two following categories. Either category 1, which you hit at least 2 points between reviewing old notes from outside notes, reviewing results of unique tests, or ordering unique tests. So if you end up ordering 2 tests that are medically necessary, you can get to a level 3 for data. Assessment required an independent historian. So if somebody needs someone else to give their history, we're not talking about a pediatric patient who of course can give their own history, but somebody who needs a family member, loved one, or another healthcare provider to be able to provide the history for that patient because they're unable to provide it for themselves. Higher level of data that you need to collect. To get to a level 4, you have to hit one of the following 3 categories. Category 1 is 3 points between reviewing old notes or outside notes, reviewing outside results, ordering a test or assessment requiring an independent historian. Category 1. Category 2, independent interpretation of tests performed by an outside physician or qualified healthcare professional, such as, let's say, a patient brings in an outside CT scan and the provider independently interprets it themselves and writes down what they found and what they think about that outside test or image. That'd be an independent interpretation of tests. Or discussion of the management with an external physician qualified healthcare provider. If you need to speak to their cardiologist to get them clearance before surgery and you document that conversation, that can be discussion of management with an external physician qualified healthcare professional. And to get to a level 5, hitting 2 of the 3 categories in level 4 makes a level 5. So data, what's important is that ordering a test is included with getting the results of that test. You can't count it twice. If you order a lab at visit 1, that includes the resulting of that same lab. You don't get points again for resulting and figuring out the results of the lab at the next visit. So that's really important to understand. Let's talk about risk. So the risk of additional diagnostic testing or the risk of the treatment. So again, these are examples. So again, minimal risk of from whatever the patient's diagnosis is or needing further testing or treatment. A low risk, again, those are not really well defined. So you have to use your best judgment if somebody has minimal risk or somebody has low risk. Moderate risk, for example, prescription drug management, decision to perform a minor surgery with identified patient risk factors. So if the patient is at higher risk than usual for a minor surgery, that makes them into a level 4. Decision regarding elective major surgery without significant additional risks. So a healthy patient undergoing a major surgery is going to be a level 4. A diagnosis or treatment is significantly limited by social determinants of health. If somebody has not had health care for decades, they're going to be a higher risk patient than somebody who has been getting regular follow-ups. And at level 5, for example, drug therapy requiring extensive monitoring for toxicity. Now, again, this isn't just prescribing a medication, which would be a level 4, but drug therapy with intensive monitoring for toxicity. Let's say somebody needs monthly labs to make sure they're not having a complication or side effect of the medication. It's not drawing labs to see the effect, but it's drawing labs to look for potential complications or side effects of giving that more dangerous medication. Decision regarding elective major surgery on a patient with additional significant risk factors. Somebody who's had multiple prior surgeries, somebody who's at high risk of dying of a heart attack is going to be a higher risk than a healthier patient undergoing a major surgery. Decision for an emergency major surgery, decision to hospitalize, or decision to do not resuscitate. Those are all level 5 risks. So then you can take those and add those together, and we'll give some examples a little bit later. I mentioned modifiers. There's 3 modifiers that we need to know about. And again, it's not you need to remember the numbers of the modifiers, but understand that these modifiers exist and why they exist. So for example, we would add modifier 24 to our E&M service if we're seeing the patient for an unrelated evaluation management service during a postoperative period. The patient undergoes a radical prostatectomy, which is a 90-day global procedure, and they come back a month later with a kidney stone. Well, obviously the kidney stone is unrelated to the prostate cancer radical prostatectomy. Well, typically anything done within 90 days of getting a radical prostatectomy has been prepaid, and you can't get paid separately unless you use a modifier to show that something is above and beyond what's typical and you should get paid. Modifier 25 and 57 are very similar. A significant separately identifiable E&M service on the same day as a procedure. So for a 0-day procedure for 0-day global procedure for modifier 25 and 90-day global procedure for modifier 57. Your initial evaluation of seeing a patient who needs an emergency surgery, cystoscopy, or stent placement that day, normally E&M services are going to be included in cystoscopy and stent placements and the like. Well, you need to communicate that, no, this should get paid separately. If you're seeing a patient for a cystoscopy for one reason, you're treating them for a different condition, it happens to be on the same day, use modifier 25 to show that this E&M service should get paid, otherwise it wouldn't get paid. So for example, let's go through some of these cases. Established patient is coming in for follow-up on their BPH, their yearly follow-up. History is medically appropriate. All their symptoms are stable. The examination document the pertinent examinations, such as a prostate examination or rectal examination. Maybe discuss, the possibly moving on to a surgical procedure to help out their BPH, but they chose to stay on their medications. How would we code this? Well, again, we look at the problems addressed. BPH is a stable chronic illness, and you're addressing one stable chronic illness. We'll get a level 3 for problems. Data, minimal to none. I mean, maybe we'll send a PSA. It wasn't in this particular example. And level and risk from additional diagnostic testing or treatment. Prescription drug management, we're keeping out of the medicines. We discussed their surgery. They chose to stay on medications, and we still sort of get credit for at least that discussion. So we've got a 3, a 2, and a 4. Since 2 of the levels hit at least a 3, this can be a 99213 because it's an established patient and it's a level 3. Established patient following up on the BPH, but this patient is worsening. So the history shows it's worsening, examination, maybe order a PSA and a urinalysis. The plan is to switch meds and schedule urodynamics. So how would we code this? Well, again, this is a chronic illness that's worsening. Our data, PSA and urinalysis, we got 2 points from ordering each unique test, so that'd be a level 3. Prescription drug management and procedures would be a level 4, so this patient would be a 99214. Established patient, level 4, because 2 of the categories reach level 4. A new patient presents with dysuria, healthy patient, acute onset. You check the urinalysis, it's leukocyte esterase and nitrate positive. You send a urine culture and start antibiotics. So I would consider, in this case, this is most likely acute cystitis. This is an acute uncomplicated illness or injury, should resolve completely. You ordered 2 tests, a urinalysis and a urine culture, and prescription drug management. So now this is a new patient, level 3, because 2 of the 3 categories are level 3. This is a 99203 patient. An established patient presents with new onset of flank pain, fevers, sent to urine culture, order a CAT scan, start antibiotics. Let's plug this in. This is, I believe, most likely this patient may have pyelonephritis or a stone. So this either can be an undiagnosed new problem with an uncertain prognosis or acute illness or injury with systemic symptoms. Either way, we're going to get level 4 for the problems addressed. We ordered a CAT scan and urine culture. So that's 2 points. That data be a level 3. And prescription drug management, start antibiotics would be a level 4. So this will be a 99214. An established patient comes to the ER from the ER with a new kidney stone. You document that you personally viewed and interpreted for yourself the outside CT scan and write in a note, I personally looked at the CAT scan and I agree there's a 6 millimeter stone in the mid-right ureter with no other stones seen, da 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 da. You interpret yourself, write that in the note. Let's say you schedule a patient for, let's say, a ureteroscopy. So this patient has flank pain, nausea, the acute issue with some systemic symptoms, independent interpretation of a test, and minor surgery with some identified patient or procedure risk factors. Because again, flank pain, nausea, and the such, I give this patient 99214. Following up with prostate cancer, the patient is worsening prostate cancer, new bone pain, reviewed outside labs from his primary, order a CAT scan starting LHRH therapy. Again, common problem. So this is a chronic illness that's worsening, so I give a level 4 for problem. 3, ordering unique tests, CT scan, PSA, bone scan. Actually, you get a 4th because you actually may be reviewed outside labs from his primary. Either way, this can be a level 4. Prescription drug management such as LHRH therapy, be a 99214 patient because 3 of the categories actually hit level 4. Remember, you only need 2 of the 3 to get there. The same patient now presents with new onset leg weakness and severe back pain. History was taken from the caretaker because they couldn't provide the history themselves, reviewed some outside labs, ordering a bone scan, CAT scan, actually determining this patient needs to be hospitalized. We're going to admit them to the hospital, maybe start ketoconazole, calling an emergency room doctor, calling a neurosurgeon to get this all going. So we can all agree this is a chronic illness with a severe exacerbation. I mean, something really bad's going on. So we ordered unique tests, reviewed the outside labs, ordered bone scan, ordered CAT scan, used an independent historian, end up calling the neurosurgeon ER doctor, discussing the management or test interpretation with the external provider. So we actually get 2 of the 3 categories of level 4, makes a level 5 patient. Decision regarding hospitalization, drug therapy needs intensive monitoring for toxicity and the like. This patient is a 99215 across the board. People always ask about vasectomy consult coding. We have to remember, typically, even though it's called a vasectomy consult, it meets the definition of being a new patient because really transferring care, you're just asked to perform the vasectomy. You're probably not seeing the patient or determining different levels of what the family may use for family planning. They're usually coming to you for a vasectomy. So putting this together, I consider a vasectomy consult potentially either a stable chronic illness or an acute, something that's acute reason to be seen that's going to resolve on its own without any real sequelae, not doing any data. And some people believe this is even if some people think this is a minor surgery, some people want to argue it's a major surgery. Listen, I probably think a vasectomy overall is a minor surgery. Either way, I can't get higher than a level 3. So we're recommending 99203 for vasectomy consult coding. We can perform telephone visits. Now, different insurers may or may not pay for this. It was really, the codes had always been there. And during the COVID public health emergency, they were paid more commonly by insurers and with rates that made sense to perform telephone visits. As of right now, these are the codes that exist, and it all depends on how much time is spent with the patient of medical discussion on the phone, choosing a 4-1, 4-2, or 4-3 based upon 5 to 10 minutes, 11 to 20, or 21 to 30 minutes. But it's important to understand that these telephone visits are not following up on a previous visit and just following up on the labs. You don't get paid just to call a patient back or return their call, but rather you're actually performing an E&M visit in lieu of an inpatient visit. So if a patient calls with an acute concern and something's worsening, maybe they haven't been seen in 6 months, and they want to do a telephone visit to determine whether or not they need to be seen or they can be managed by telephone, that would meet the criteria. If it ends up the patient, you need to send the patient to emergency room, get them in for a visit or do a procedure on them, you can't use that as telephone visit because it has to be an established patient, not originating from a related evaluation management service, especially within the last 7 days, nor leading to the next available E&M service or procedure within the next 24 hours or the soonest available. If you meet the criteria for a true evaluation management of the patient that doesn't have any of the exclusions, you can bill the telephone codes. There's a similar code that's a CMS only code for a brief check-in. The brief patient needs to check in to see if they need to be seen or not, or they can be managed as an outpatient. Hospital E&M visits, and again, it's important to understand the difference between a hospital inpatient observation unit. And remember, unlike the office setting, where you have new and established and consultations, hospital billing is the initial visit during that hospitalization, subsequent visit during the hospitalization. So even if the patient is established to you, they can, every time they're admitted to the hospital and you see them, it would be an initial visit and subsequent visit, which is different than a new patient and consult that you would do as an outpatient. So understand that these codes exist. Thank you for your time today.